Unknown participant is now joining.
Of course I see it.
Am I in the right place? Can anybody hear me?
I can hear.
Yep.
Unknown participant is now joining.
Oh,
Unknown participant is now joining.
how do we get rid of unknown participant is now joining? Hi, Rita.
Hi.
I keep getting the unknown participant is now joining message.
That might be a couple of people filtering in who had issues with Teams.
Oh, what's all that stuff?
I'm gonna mute everyone. Bill, unmute yourself.
I don't know if anybody can hear me.
Yes, you and I are the only two people who are unmuted right now.
Ah, okay. Okay. So the first thing that I need to do is upload the slideshow, right?
Mhm.
And this is not it here. Browse and upload from my computer. Desktop. That's not it. Is that it? Yeah. Is that the right document, Rita? I think that's the, if that's the PDF, then I guess I should do the other one, right?
Yes, the PowerPoint.
The PowerPoint. Okay, make sure I
Hey.
got.
Bill, your video is off. I don't know if you want people to see your lovely face or not.
Oh, gee.
I see Bill.
Oh, you do? Okay, maybe my computer.
Um, yeah, I video. Can anybody see the upload, the download of the PowerPoint?
Oh, damn, that's nice.
Yes.
Yes, see the power.
You see the PowerPoint? Okay. So, oh, there it goes. I think I see it too. So everybody, I don't know if you can hear me. Thank you for coming. There's so many of you on the list here that I'm really nervous. Wow. Okay. I guess I better be good then. Can everybody download this slideshow so that they could scroll through it as I scroll through it so that maybe we don't have to both be on the same page at the same time?
So, Bill, I think you just uploaded the PowerPoint as like a presentation right now.
Yeah.
They can go through the slides. It says like slide 1 out of 83 right now.
Yep.
Click through, they can absolutely do that. And then if they want to return to whatever page you're on, there's a button that says to presenter and it'll bring them back to whatever page you're on. However, they don't have like the actual file downloaded, which we can either attach at the very end into the chat, which Laura just said, which I think you also wanted to do with a PDF that we were going to use later.
Right. Okay. So should I try to load that PDF now so that we don't have to do it later?
I would say let's wait so that it'll be the last thing at the bottom. Everyone can click at the same time.
Great. Okay. So if everybody has an opportunity to see the slideshow, I'm just going to ask you to take the first 5 minutes to kind of scroll through it just so you can get a sense of not just where we're going, but I'm not going to be able to do the whole slideshow because I know that people do want to try to go home from home at 4:30 and or so. So I don't want to really keep you till 5 unless there's a lot of Q&A at the end. So if everybody can indulge me with the, just scrolling through. That way, if you have any burning questions when we get to a particular slide, you can ask. Otherwise, maybe hold your questions till the Q&A. I think that's how it works best.
Hey, Bill, I think Gittel actually said that we were running maybe late on time and wanted to start now.
Start now. Okay, so we can start now. Okay. All right. Well, let me start by saying that this presentation of psychotropic medication is something that I put together because when I was teaching at the Hunter School of Social Work, one of the things I noticed was that there's not only very little clinical information, few clinical classes, but when I first got there was absolutely nothing at all on medication. After a couple of years, they did allow the instructors to bring some information about medication to the classroom. So I did that, and this PowerPoint is just sort of like an extension of how I would teach that class. And if you remember when you were in MSW program, the classes were about at least 2.5 to 3 hours long, something like that. So that's why I'm going to try really hard to, just squeeze this in. It's important, I think, that we owe our clients to know something about medication. Again, because we didn't really learn too much about it, but most of my clients are on medication or have been on medication or will be on medication at some point. So that's why I feel pretty passionate about social workers getting to know more about it if they're not familiar with the medications. Because also if we don't do it, then we leave the field to the psychiatrists only. And that I don't think is going to be great for our clients. So if we could just kind of scroll real quick to table of contents, which is slide 2. You could take a quick look, and that's the order we'll be doing things in. Right? And I'd like to begin the slideshow or the talk with some definitions, because we don't always define very well what we're talking about. So let's get to definitions. So the reason I use the term psychotropic, there's a lot of different terms that I could use, like psychiatric medicine, mental health medicine. I feel like psychiatric medicine is a little bit pejorative, right? It's like, this person needs a psychiatrist. I'm not sure. Maybe that's just the way I think about it. Psychotropic feels a little bit more neutral and a little more accurate. So it comes from the ancient Greek. I hope you're all really conversant in how to read Greek, but if you're not, then it's interesting that psyche means soul, breath, mind, or spirit. You know, we tend to think of it only as something in the mind, and the Greeks had a little bit more of a robust sense of what that word is to mean, and tropos to turn. So it's the turning of the mind, obviously not necessarily for the better. Okay, we're going to skip through, and I'm going to take you to slide number 7, which is my own definition of the term psychotropic and medication. The previous slides had definitions from dictionaries in various places. I don't like them. I don't like any of them, so I make up my own. And you could see that it's the psychotropic is a change in mental activities. It includes your mood, emotions, perception, cognition, and it's and medication is a compound that's introduced into the human body, either intentionally or unintentionally. Okay, so let's go to slide number 10. Well, we'll just stop very briefly at 9. This is the definition of mental illness from the point of view of the DSM. That's only one way of looking at it. The DSM is basically an American version of psychiatry, not necessarily the way they see it in the rest of the world. It's very lengthy. I'm not going to read it. You can always go back to it later. But what we do know about mental illness, psychopathology, whichever term you want to use, there are 5 basic descriptions that every definition would probably include. Causing personal distress, processes are maladaptive, deviates from cultural norms. That's really important because different cultures have different ways of looking at what is and isn't healthful. And we have to be very careful. I think as social workers, we all know that. But I like particularly also number 5, which is the inability to consider alternative ways to think, feel, and act. That tends to be pretty common in many of the dynamics that go on in mental illness. So if we could go now to slide 11, we will see just some quick stats that are kind of relevant to what we're talking about. I just lost my slideshow.
Yeah, I think you exited out of the presentation. I think you might have to upload it again.
I did? I have to upload it again. Oh boy. Not sure how I lost it. Okay. Where is the upload feature here? Share. Oh, is that it right there?
Great. I think you said that you were on slide 11.
Yes. Are you
Great.
seeing that? Because I don't see anything on my screen.
I am seeing the first page.
Oh, now I got it. Okay. I apologize, everybody, with the technology, but you have to remember, I was born in the last millennial, or even I think maybe the one before that. And so this stuff is kind of a little bit difficult for me to kind of work out all the time. So there we go. We have this statistic you're going to find varies a lot. How many people are considered or diagnosed as mentally ill in the United States? I've seen 1 in 4, 1 in 5, 1 in 6. So it depends on who is doing the research. But I put this slide up because you can see 20% of state prisoners and 21% of local jail prisoners have a recent history of a mental health condition. We may suspect that it's higher than that. I certainly do. 70% of youth in juvenile systems. And of course, we are always worried about suicide the potential of suicide in our clients. Okay. Now, one thing I don't want to do is lose this slideshow again. Not sure how I did that the last time. Okay. So we're going to begin the real part of this show with slide number 12. And I'm going to start with a little bit of a history of mental illness treatment. I hope you both you all can recognize the picture on the left. And anybody, if you don't know the picture on the right, that's from that's Christian Bale in American Psycho. All right, so I have a bad sense of humor. What can I tell you? We know that mental illness was known probably since the beginning of humankind. Written histories from ancient Greece in the 6th century refer to command hallucinations. We know that Pythagoras heard voices, and a little bit later in the 5th century, Hippocrates classified mental disorders, and he included paranoia, epilepsy, mania, and melancholia. Melancholia is an earlier term for depression or depressive disorder. And we know also that Hindu texts from 7th century BCE reference depression and anxiety. Ancient Mesopotamia had texts that reference hallucinations, familial insanity, and erectile dysfunction. Those are some interesting documents. Chinese medical documents, 12th century BCE, referencing trauma, emotional distress, and other disorders of body and mind. And the last one is Egyptian papyrus, one of those, also references emotional distress. So we know that people have been struggling with this concept for a very long time. Now, there's also reason to believe that as far back as 7,000 years ago, that people were trying to work out how to help people with any kind of mental illness. We found skulls all over the world. It's called trepanning. It's a procedure where drilling into the skull was done. And we believe that it was a medical procedure, possibly for epilepsy or other mental health symptoms, but it's also likely to have been used as ritualistic. But I think that I like the idea that back then it was recognized that some of us needed mental health help. Okay, so we're going to skip over, just very briefly, want to show you, you can scroll through this later when you download it. But in ancient Rome, that's the first time that this idea of insanity as a legal defense was conceived. It was called non compos mentis, which means the no power of mind. However, it's very important to know that it strictly meant that somebody would have had to have completely lost their mind, which is a little bit different than the way we might use the insanity defense as public defenders. Okay, now we're going to go to, we have the history of mental health treatment in different countries like the US, China. And now I'd like to give you the beginning of the history of the medications themselves. Antihistamines, you've heard of them. They were developed in the 30s for nasal allergies, and it was noticed that they produced sleepiness. It worked on the receptors of the brain, and people started to wonder, scientists anyway, whether it could calm the positive symptoms of schizophrenia. And that was always a very important thing that people were trying to find, because schizophrenia was certainly recognized for the last couple of 100 years, if not a lot more. And the florid symptoms, the positive symptoms, as you probably know, which are different than the negative symptoms, are the ones that cause so much of the problems, right? Hallucinations, in other words, hearing voices, delusions, things that really disorganized thinking. These are the things that really inhibit people that have schizophrenia. So there was always a sense of wishing that we could treat at least those symptoms, if not the negative symptoms. So it turns out these antihistamines were tried as treatments for schizophrenia, but they didn't work. What did work was in the 50s, this was the magic bullet, or what we call the game changer. And this is chlorpromazine. Some of you may have heard of it as Thorazine. Does that sound maybe familiar to anybody? Yes, thank you, Laura. Yes, you've heard of it. A lot of people have heard of Thorazine because it is still prescribed, and this is 60 years later. It was first tested on a manic patient and proved to be very effective for delusions and hallucinations. It was considered a miracle drug and more effective than ECT, which they were doing at the time, electroconvulsive therapy, shocking people, which we still do, by the way, for depression, depression that isn't treatable or doesn't usually respond to treatment, ECT. We don't do lobotomies anymore, as far as I know, unless
Unknown participant is
maybe in
now
other
exiting.
countries, not quite sure. But anyway, the success of this drug stimulated more research in the development of other drugs. And we then come up with another, these are like the great grandparents of psychotropic medications. And imipramine. Sometimes you see it still prescribed. Most likely, we as social workers won't see it too frequently, but imipramine was the first antidepressant. They tried to develop it for the, psychotic features of schizophrenia. The positive symptoms didn't work, but we found that it was very effective on depression. It works on many of the neurotransmitters, including dopamine, serotonin, norepinephrine, epinephrine, and others. This actually took off. At first, when scientists developed this, they weren't doing much about it, but one of the big wigs of the Ciba-Geigy company that developed it, his wife had depression, so he insisted on trying it out on her, and it worked, and that's how this drug got pushed into the forefront. Strange. Okay, let's get to, this is what we know about psychiatric medications. With very few exceptions, and I'll point one out when we get to the mood stabilizers. They're nearly always artificial compounds. They're synthesized in a laboratory. I don't know if anyone knew that, but they don't occur in nature, right? Everything that you've heard of, Seroquel or Celexa, Prozac, all of these are invented in a laboratory. And they affect the transmitters in the brain, for the most part. They can be prescribed either by brand name or in a generic form, depending on how new the particular drug is. So fluoxetine is the real name of Prozac. I'm sure you all know that there's a real name of these medications, and then there's the brand name, which is the ones we're probably more familiar with, like Zoloft, right? So, but anywhere where we need it, I'm going to show you on the slides both the brand name and the generic names. Just about all of them will have some side effect, often unwanted, but they may be short or long acting. So sometimes a lot of people, they don't really like the medications they're on, but often if they stick with it for a little while, the body will get used to processing it, and many side effects will go away, not always. It's also important to remember that none of these medications ever cure anything, right? They don't cure anything. What are they for? Symptom relief. That's about the best that we can do now. So, you know, it ain't penicillin, right? Penicillin, you know, that's going to cure your STD. All right. Now let's get to next section is going to be how you identify some of these medications. Now, if you notice on this slide, I used the term prescription medication as opposed to psychotropic. Why did I make this switch? I made the switch because we're going to be primarily concerned with the medications that doctors in the field are prescribing, right? We're not going to be talking about other psychotropic medications like LSD, ketamine, cannabis, MDMA, ibogaine. You may have heard of some of those. Those are all, they all have psychotropic properties. Well, actually, cannabis is now being prescribed, right? So maybe we could take that off the non-prescribed list. I mean, the forbidden list. But that's why I use the term prescription medication at this particular time and not just all psychotropic. Anybody getting off the highway here? Okay. All right, I think if we're now on slide 28, what we will see here are the different classifications of medication. Now, these terms that you're looking at, antipsychotics, anticonvulsants, mood stabilizers, antidepressants, and anxiolytics, these are not scientific categories. In other words, there's no book that says anxiolytics are, you know, developed in a particular way. These are the compounds. These are just the descriptive terms that we use for different classifications of medications. So you're probably going to be familiar with the term antipsychotics, and in a couple of minutes we'll get into the difference between typical and atypical antipsychotics, because there's basically two branches of them. And I will give you a handout later towards the end of the presentation, and it'll be like a cheat sheet. I think you'll like it, and it's going to have most of the common medications that are being prescribed now in a nice little chart that really works pretty well. Anticonvulsants, which were originally developed for epilepsy, seizure disorders, things of that nature. Although now we find that these anticonvulsants do work on certain mental health symptoms. You're all familiar, I believe, with most of these antidepressants. I would assume that just about every social worker would know the term SSRI. selective serotonin reuptake inhibitor. It affects your serotonin level and keeps more serotonin in your bloodstream, because apparently there's a belief that there may be a lack of that neurotransmitter, and that causes depression. You may not be familiar with the MAOIs or the tricyclics, but I'll get into them a little bit. And then the anxiolytics are basically, anxiolytic just simply means, it's really simple, that these are drugs that are prescribed for anxiety. And you can imagine there's all kinds of anxiety, and there's all kinds of, all classes, kinds of drugs that are used to combat anxiety. You've probably heard of benzodiazepines. Now, beta blockers were originally, or still are actually, beta blockers are used for high blood pressure. People who are on medication for high blood pressure, they get beta blockers, but they reduce anxiety. So, thank you, Alicia. Other terminology for anxiety drugs are sedatives, tranquilizers, and hypnotics. These are often interchangeable. So you might be reading in your client's file that a sedative was prescribed or a tranquilizer. What does that mean? Well, the meanings are a little bit fluid and amorphous. You'd have to know what drug specifically they're referring to, because these terms are used somewhat interchangeable. Although I will say that hypnotics generally refers to sleep medication, like Ambien, like you'd probably be familiar with Ambien. I don't know what the prevalence of the use of any of these drugs are, but you can certainly Google that. I do have some statistics I'll be getting to. These are the most prescribed drugs, 10 most prescribed mental health drugs. Yes, high blood pressure medication or the beta blockers they're used for anxiety. Somebody asked, okay. Here are the 10 most common psychotropic, psychiatric medications in the United States today. And I think you'll see some of the usual suspects: Zoloft, Xanax, Lexapro. Probably, if you're a social worker, I've heard, my guess is going to be that you've heard of each of these because they're that commonly prescribed. You can see they're basically, for the most part, anxiety and depression medications, with the exception of Adderall, which is the treatment for ADHD. Now, if you'll notice, these statistics come from 2016. I literally could not find more updated statistics from either 2017, 2018. I looked. If anybody does find some, please let me know and I'll adjust the slide. But this is as well as I could get. So as of 4 years ago, you can see what America is eating, so to speak. I also gave you, oops. Oh. I also, where is the, this slide seems, we're missing something from this slideshow. Well, I had a slide, I guess, I'm not sure what I uploaded to this PowerPoint here, but I have another slide if you're interested on numbers 11 to 25. And there you're going to start to see some, Wow, where's that? How's that going? There you'll start to see some of the antipsychotics, right? Because they're not prescribed quite as often as the antidepressants, let's say. Okay. Okay, so where do I go here? I just lost my screen. Sorry about that, everybody. That just keeps taking me away. Did that come back now for everybody?
Yes.
Okay. So I just need to skip ahead to, how do I get all the way up to?
Unfortunately, just a lot of clicking.
Yeah, I think, didn't we have it a little bit easier earlier today? I don't remember. Okay, we're gonna get back to how the medication is actually prescribed. The red pill and the blue pill. Do you remember the matrix? Which one would you rather have? If you haven't seen the matrix, please watch the matrix because it is real, believe it or not, in my opinion. Okay. Who can prescribe drugs? Psychiatrists can prescribe drugs. Some psychologists, but basically it's left to the medical field to do the prescriptions. How do they know how to make, how do they know how to make the correct, to prescribe the correct prescription to people? Well, that's what they are supposed to be trained in. So this is one of the reasons why I don't recommend that people go to their family doctors for psychotropic medications. They're generally not trained very well in terms of, I mean, they just don't know as much as pharmacologists. So they're apt to get it wrong, and they don't have the robust knowledge that a psychiatrist would have. Any doctor, though, can prescribe any medication, which is why your family doctor can prescribe these medications. But I recommend, if you have clients that can access, obviously you want to access the best psychiatrist you can. I believe that a good psychiatrist is really the holy grail of mental health treatment. I don't know how you get a good one. You know, a lot of private psychiatrists charge $600 an hour for the first hour. Maybe they give you a break, $300 or $400 an hour for your follow-up visits. Maybe you're lucky and you get more than a half an hour with the doctor. So if you do find a great psychiatrist, let your friends know, let me know, because I'm actually trying to refer some of my clients in private practice to good psychiatrists, and the one that I used to refer to is no longer taking patients, and I have literally nobody that I trust that I would send for good pharmacology. I'll just give you a real quick anecdote. When I was training as a therapist, outpatient clinic, it was called the Fifth Avenue Center, we would routinely send our clients, we would interview them, they'd be assigned to a therapist, and then they would have a psychiatric interview, usually about 3-4 weeks into the treatment. So I had a new client and I referred him to the psychiatrist. And when he came back to the next session, I asked him, how did that session with the psychiatrist go? And he just said to me, all I want to know is who's his psychiatrist. So psychiatrists do have sometimes a reputation of being interesting. Let's put it that way. Okay. This is called the bipolar decision tree. And this is how psychiatrists think about their options depending on the presentation of their patients. And this decision tree I call, if this, then this. So I'm hoping that you can see it well enough to be able to read, but I'll read through it for you. So right at the top, a patient comes in and they are expressing or revealing mood symptoms, right? Maybe they discuss it, or the therapist or the psychiatrist intuits that there are mood symptoms. The first thing then, if you look at the arrow going down, is there an obvious medical cause? I mean, if somebody just came to you and they were diagnosed with some fatal illness, it's a good possibility that that depression might be related to a medical issue and not so much maybe a long-term long-term symptom. So if it's yes, and there is a medical treatment, a medical cause, then we treat that medical illness first. So you can see depression frequently does coexist with all kinds of medical illnesses. However, if it's not obviously a medical issue, so that's no, the first thing we want to know is there mania? Is there mania now, or is there a history of mania? Now remember, this is just for bipolar. This is not necessarily for every other illness, but they all work in the same way, if this, then this. At least that's how doctors think about it that way. So, mania symptoms, let's see. If there are no mania symptoms, and do we know what mania is? I hope everybody knows what mania is. Yes? Mania is the up part of bipolar, not the depressive pole, but the pole where you're grandiose, your energy levels are very high, you're doing 17 things at once, maybe you're being promiscuous, or you're cooking for 48 hours in a row. I think we all know basically what mania is. So if there is no mania apparent, now we're going to look for depressive disorders like major depressive disorder, dysthymic disorder, or another version of some kind of depressive or anxiety disorder. However, if we do see mania, now we've opened up a bit of a can of worms, because mania could come with many cohorts. They often don't just show up to the party by themselves. They bring a lot of friends. And what I mean by that is, if you look at the yes, if you see psychosis, delusions, hallucinations, many times in the bipolar manic phase, you may also have psychotic symptoms, okay? And you will see here that there's a differential diagnosis, and that will give you bipolar disorder with psychosis. They're not the same thing. There's also schizoaffective disorder, which is bipolar disorder and schizophrenia sort of together, but that's still not the same as bipolar with psychosis. If your brain is not exploding by now, I'm amazed that you're understanding this. Basically, it takes a long time to be able to distinguish between these different disorders, which is why often when you see your client's records, how many times have you seen the client has been diagnosed schizophrenic, and schizoaffective and bipolar, and 2 or 3 or all of those combinations at the same time. It can't be all 3. The real diagnosis can only be schizophrenia, schizoaffective, or bipolar. And the reason we want to make these distinctions is because that's how we'll know how to treat it best. Now, if there is no psychosis and all you're seeing is mania, now you can go this way and you can distinguish between bipolar 1, bipolar 2, and another form of bipolar that is not easy to describe or we don't have enough information. They use the term NOS. It's not used anymore, not otherwise specified. We have new terminology for that. But you'll still see NOS a lot of times in your client's files. So this is just an example, even if you didn't follow everything completely, how it is that the psychiatrist is thinking, well, I have this, and I know I don't have this, so that eliminates those, leaves a few of these, and then eventually you eliminate until you figure out what you think the correct diagnosis is, and by that, you'll be able to appropriately prescribe the medications. Now, I did give you 2 more slides of how different versions of a diagnostic tree or a decision tree. I'm not going to go through it, but when you get your slideshow, you can have a look at it. It's just a different way of describing what you saw before. Okay. Now, what else are doctors concerned about? Well, they have a lot to be worried about, right? How to get the diagnosis right. What do you have to do to make sure that even once you get the diagnosis, that you're now going to prescribe the right medications? Excuse me. Okay, so here are some terms that doctors know that would be helpful, I think, for us to know. Now, medications are divided into indicated and off-label. And what does that mean? Well, we know that Prozac, for example, or Zoloft were created for depression, right? That's what the pharmaceutical companies that own those brands will have their salespeople tell the doctors. This drug is indicated for depression. However, doctors frequently, very frequently, will prescribe a drug off-label, meaning that they may prescribe Prozac or Zoloft for anxiety disorders, for trauma, for personality disorders. So most of these drugs will have multiple uses, but the FDA has not specifically sanctioned off-label use. Okay? It's not illegal to do it, but there has to be a distinction between what the drug is actually developed for and what it isn't. Doctors also need to be very concerned with what other substances that a client might be taking, including over-the-counter medications, right? Maybe they're taking one of the things that they get in the health food stores. You know, people have the, what are those natural antidepressants called? You all know, I can't remember, but you know, you can see where I'm going. We have to be careful because all drugs, St. John's wort, thank you. Thank you very much. That was very helpful. Yeah, St. John's wort. Okay. Yeah, every chemical you introduce into your body at every time is interacting with every other chemical that's been introduced into your body. So you have to be careful because some drugs don't work. They don't play nice with others very frequently. Now, a term that you'll hear frequently is PRN or pro-Renata, and that's the opposite of daily use. So for example, when you get an antidepressant like Celexa, Lexapro, Zoloft, any of those, in order for it to work, you have to take it daily. Sometimes twice a day, depends on the medications, but for it to be effective, it's called daily use. PRN medications are things like Xanax that, oh, Brenda, yes, the sign-in sheet, that's great. Okay, you can speak if you need to. I don't know if you want to make that announcement, Brenda. Okay, we'll wait and see.
People, just by the way, we're a little over halfway time.
Yes, and I think that we are definitely more than halfway done. Pro-Renata is something like Xanax that you take on, or Klonopin that you take on an as-needed basis. Okay, you don't take it all the time. And we have to figure out how to, or the doctor needs to figure out how to begin the prescription, because you don't want to immediately prescribe what we call therapeutic dose. We start with a lower dose to make sure that the person can tolerate that particular medication. Okay, so different people have different responses to medication. So the reason that cultural competence is here is because we have determined, or we have learned, that people from different backgrounds, different ethnicities, and so forth, have slightly different body types. I mean, we're all the same, but what we have learned is that, for example, if you're going to prescribe the blood pressure medication like propranolol to African Americans, that you want to start them on a higher dose than on other people because their bodies have a higher tolerance for it. And this we have discovered over time. Similarly, Asians, you have to start them on much lower doses of many of these medications because they process it very quickly. They have a much lower tolerance. So these are things that doctors have to be concerned about and things that we have learned over time. Okay, and if you look at your slideshow later when you have time, there's a slide that will explain to you what titration means, and that's how the doctor determines the buildup or the building down, the reduction of a particular medication, because many medications, you can't just stop them immediately. Your body frequently will not like that. And, you know, doctors are concerned with the absorption, the distribution, the elimination of these medications. You can take a look at the slideshow later. What is the #1 reason for failure of many of these medications? Believe it or not, is patient non-compliance. Are they following the plan? Okay, do they understand why they're taking it? Are they on board with it? Okay. What can we do if we find that our clients are not responding well to the medication? Let's try to get permission to speak immediately with the MD, right? And refer to an MD, or contact the MD that's already in place and discuss the possibility of whatever you're seeing, whether it's psychosis, ADHD, some medical etiology that everybody's gotten wrong. And in fact, they think that it's the symptoms are basically coming from mental health issues. These are the things that you can discuss with the other providers on your team. Okay, now the last part of the presentation is to get into the disorders and which medications are prescribed for what. So I'm not going to go through this, but you have a slide if you want to look at it later. The categories that the DSM is classified into, and there you see the rest of the categories. We're going to start by talking about psychotic disorders. Obviously, they're very common. We see this in our practice very frequently. Unfortunately, I think too frequently. We know what psychotic disorders are. Generally, we're referring to delusions, hallucinations, paranoia, disorganized behavior. Sometimes it comes with the withdrawal from their family and friends. And we often will see a decline in self-care. You know, their hygiene changes. They become more suspicious. They have trouble thinking clearly. These are all symptoms of psychotic disorders. And we're back to our ancient Greek, which psyche, soul, the mind, and in this case, an abnormal condition. That's what psychosis means. That's what the original derivation of that word is. Psychotic disorders, I'm not going to give you all of the requirements to make that diagnosis. In other words, in the DSM, it will describe what symptoms you need to be seeing in order to attribute whether somebody has a delusional disorder, brief psychotic, schizophreniform, schizophrenia. Each one of these disorders has discrete requirements for the patient or client to show, to present with, in order to make an effective diagnosis. So you always have your DSM to look at, or if you don't have the, everybody, I hope you can get this. Can you see this? No. That's the little handbook. It's called the Desk Reference. It's not very expensive. I've seen them for as little as maybe, oh, it'll be uploaded? Okay, great. You can find these on Amazon for $12, $15. Anyway, I think it's great if you carry it around and read it on the subway. When you used to be on the subway, now you have to read it at home. But anyway, it's a very quick way of remembering what the criteria are for these disorders, because most of our social work team will know most of the symptomology, but may not remember every single one. So your little DSM desk reference is really nice to have. Okay, what do we treat psychosis with? The typical antipsychotics. If you can remember the term typical antipsychotic. Now, these medications are generally not the first time options. It's a group of medications called typical. You'll see it later on the chart. They're effective medications. They're generally not the first line medication. There are atypical antipsychotics, which over the last, I'm going to say now 30 years, certainly 20, are more commonly prescribed for medications for psychotic disorders. So anybody know why you would call the more prescribed drugs atypical and the less prescribed drugs typical? Does that seem backwards to anybody? Well, here's your answer. The typical antipsychotics were the first drugs that were developed in the 50s. And the second generation of drugs, which were approved in the 90s, they're called the atypicals. Second generation. These came about, obviously, much later. These are the ones that we are nearly always going to start someone off on, are the atypical antipsychotics. Now, let's just go back again to the beginning. These are the typical ones. Now, if you remember, chlorpromazine was the game changer. That was the very first one that came out of the lab. And then these other ones came out in the 50s. They blocked dopamine receptors. That's how they work. You likely will see Haldol and Thorazine still prescribed with some frequency. The others, I've seen them, but less so. Now, the atypical ones are probably the ones that you are most familiar with. I'm sure most of you have heard of Risperdal, Cyprexa, Seroquel, Abilify, Latuda, Clozaril. These you'll find in our clients' charts all the time, either by the brand name or by, their real name. Okay, so it's only when these are not working for the client that we go back to prescribing the typical antipsychotics. Usually it's for, those clients whose psychosis is so entrenched that it's the newer ones are just not working. And these older ones work very, very well on these positive symptoms, the hallucinations or delusions, disorganization. They don't work quite as well. None of these actually work quite as well on the negative symptoms. And if you remember, the negative symptoms are, anhedonia, the loss of interest, loss of pleasure, lack of motivation, things like that. So those are your psychotic disorders and how they're basically treated. Those are the two kinds of medications: typical, atypical antipsychotics. And antipsychotics are also called neuroleptics. Now we'll move on to the bipolar disorders. And you can see what a normal brain is supposed to look like. And then you can see bipolar changes in the brain. And we look at it this way, we know that there is a genetic etiology. Sorry. I saw Natalie's question, but I didn't actually understand what it was. Let's go to bipolar disorder and related. So there's bipolar 1, there's bipolar 2, and cyclothymic disorder. Just very briefly, I'm not going to give you all the symptoms that need to be present, but we know that bipolar 1 is the most disabling of them all. And it's bipolar when the client has experienced or reported 7 straight days of mania. Okay, 7 days, that's a long time. And you can be sure that if somebody has 7 days of mania, they end up in the hospital. You can nearly always be sure. Bipolar 2 is hypomania, meaning a 4-day manic event with alternating depressive disorder. Now, this is important because bipolar 1 may have depression, but that's not required for the diagnosis. It usually does, but it doesn't have to. Mania is the concern. Bipolar 2 is a combination. We're concerned about the mania and the depressive disorder. Cyclothymic disorder is like a bipolar light that lasts for 2 years. You never get the full mania. You never get the 7 days or the 4 days of straight mania. You get maybe some hypomania that lasts less than 4 days. And this disorder will generally drag on with depressive symptoms for minimally 2 years. So, what do we use to treat the bipolar disorders? We use mood stabilizers. Now, you've heard the term mood stabilizers. They are not antidepressants. They are sometimes called anticonvulsants, which we heard a little bit earlier that it's for was originally for seizure disorders. Now, you may recognize some of these. You certainly would know Depakote if you're a social worker. You'd probably see this as often as you see the word mood stabilizer or treatment for bipolar disorder. All of these are currently used, but let's just look at number one. This is lithium carbonate. Lithium carbonate is the one naturally occurring organic element. Everything that we've talked about, this is literally organic and occurring in nature. And guess what? For some reason or other, it is by far the best way to stabilize people who are going from manic phase to depression. Lithium. Why don't we give lithium to everybody? The reason is because lithium has a very significant effect on your kidneys, not the liver, but the kidneys, and sometimes on thyroid conditions. And they can get very toxic very quickly, or it can get toxic very quickly. So we want to make sure that the client is being monitored and tested when they're on lithium, probably every couple of weeks at the beginning, maybe every month if they're tolerating it. Now, a lot of our clients don't sound like people that are lucky enough, fortunate enough, or have the ability to start off on the lithium. So more often than not, they're going to be prescribed Depakote. And Depakote works very well, not as well, but it's very effective. So that's probably the one you'll see the most frequently, Depakote and sometimes Lamictal. And I've seen the others often too, Tegretol, but basically these first two are the ones that you're going to be encountering more often than not. Now okay, I think that's, now don't forget, a lot of these drugs are sometimes prescribed in combination with other drugs. And that's a decision that the doctor makes because of experience. We'll probably get into, we're going to get a little bit later into polypharmacy, which is more than one drug interacting with each other at the same time. How am I doing on time? We're getting there. Okay. Depressive disorders. Depressive disorders. What do we need to know about depressive disorders? Here we go. Global antidepressant use per 1,000 people. So Korea, not so much. Soviet Union, not so much. But if you go all the way down here to the United States, we win. USA, USA, yes. Yes, we're very good. We're a beautiful country. Yes, we're very strong with antidepressants. You know, whatever. Okay. You get the idea. Depressive disorders, there are several of them. The ones in the DSM are listed right here. One is a disorder of childhood, and the other ones are the common depressive disorders. Now, there are actually millions of depressive disorders because every human being is really different from each other. So one's depression doesn't necessarily look like somebody else's depression, right? But they're categorized in these broad strokes. And there's a really interesting story, if any of you are interested. I'm not going to go through it, takes too long right now, about premenstrual dysphoric disorder, which is in the DSM. And if you're interested to know why, or you're angry about that or happy about it, we can have a side conversation another time. But it was a very controversial event that got it included into the DSM. Very interesting story. Okay, the oldest antidepressants were called the tricyclics. When I was growing up, a lot of friends' moms were on Elavil or Norpramine. You know, the old 50s housewives were not typically happy people. Okay, I'm generalizing, it's just a joke. But the tricyclics are the original antidepressants. You very, very rarely see them prescribed now. They were very effective, but the side effects were too substantial so that we don't use them very often today. Now, after the tricyclics, the MAOIs came about. These are the monoxamine oxidase inhibitors. These are the most common ones. What is a MAOI? A MAOI is it's an enzyme that affects several of the neurotransmitters in your brain. Nardilparnate MSM, which is a patch, not often prescribed anymore, but probably these are the very most effective antidepressants. They work better. These three work better than all the ones that you basically know, the SSRIs, the SNRIs, but they have very severe side effects. And you have to be really careful. Like most of these don't react well if you drink alcohol or eat certain aged cheeses. I'm not making this up. You have to let go of the Parmesan. Because though in combination with this drug, it leads to hypertension, and it comes on really fast. It's like a hypertension crisis. Also, no dried sausages, sauerkraut, soy products. So you can see why it's not going to be prescribed as readily as we would like. But they do work really well if you could stay away from all those foods that you like. So now we come down to the common, very common drugs for depression. I'm sure you recognize every one of these SSRIs, I would think. We see them these first two are so common, Prozac, Zoloft, Celexa, and Lexapro. Paxil, they've started to come off Paxil, very common in the 90s, but it's a weird SSRI, and a lot of people, when they go off it, have these lingering after effects. We try to avoid Paxil if we can now, but it's still including SSRI prescriptions. There are SNRIs that work on both serotonin and norepinephrine, and I'm sure you've heard of many of these. Cymbalta, I think that's advertised on TV. Effexor, Pristiq, Strattera. These are relatively common, especially these first two, Cymbalta and Effexor. Let's go to the next slide. These are my favorites. These are the drugs with no class. I like things that have no class. They don't fit into any class. We don't actually know how they work, but look into your client's charts and you are going to see Wellbutrin, right? This is prescribed very frequently. Remeron also. Remeron, a little bit different than Wellbutrin, has a nice little sedative quality. So Remeron is really good when you want to go to sleep at night. Wellbutrin is good for the daytime. I mean, all of these little understandings of how each one of these varies from one another is what your pharmacologist, that's what you're paying for, right? They know. So for example, just as an example, I'll go back to these really common SSRIs. You know, you start off somebody on a low dose, you eventually titrate them up, and you ask them to please stay on it for 6 weeks because the effect doesn't begin to, it doesn't begin to take effect for at least 3 to 4 weeks, 3 generally at the minimum. And all of these drugs are very much like each other, but there are some differences, like Prozac gives you more agitation and energy. So if you're normally like a pretty hyper kind of person, then Prozac is probably not the best one for you. Zoloft is very popular. So is the #1 drug because it's probably the most neutral. Celexa is really effective, but you'll get a lot of weight gain, often, not always. You'll get weight gain side effect and a diminished libido. This is a lot of our clients, a lot of people I know complain about a diminished libido on Celexa. When the psychiatrists hear that, they add Wellbutrin. And for whatever reason, Wellbutrin and the Celexa work very nicely together to restore your libido, if that's what you want. Okay, those are the depressive disorders. So yes, I'm running through. Looks like I should just about make it. Schizoaffective disorder, the most difficult disorder, I think, to diagnose. No, where did we go? That's not where I wanted to go. Yes, it is where I wanted to go. What is schizoaffective disorder? We talked about it a little bit before. It's like a combination of bipolar and schizophrenia. The best way that I can describe it is if you've got bipolar disorder, you're either in the manic phase or you're in the depressed phase. That's bipolar disorder. If you have schizophrenia, you have psychotic features, hallucinations, delusions. Schizoaffective disorder is interesting because it's almost always misdiagnosed. There's almost never enough information to make the diagnosis properly. And I've even met some psychiatrists that they go to the DSM to make sure they know what they're looking at. It's really difficult. But basically, real quick, if you have bipolar disorder and all of a sudden, no more mania and no more depression, the symptoms are gone, but instead you have psychotic symptoms for 2 weeks, minimally, not in conjunction with the mood disorders. So it's really a specific disorder that's neither schizophrenia nor bipolar disorder. And you want to be able to effectively treat that. And one way you can treat it is with what we call polypharmacy. And so generally you'll get a mood stabilizer, excuse me, a mood stabilizer, as we saw with bipolar disorder, an antipsychotic, as you would see with schizophrenia. What can I tell you? And an antidepressant, okay? So you'll frequently see what we call a treatment cocktail. And sometimes there might even be a 4th or a 5th medication added to that. Okay, we're going to get over to the anxiety disorders. And there are several of them, and you've probably heard of most of them. Separation anxiety disorder, mostly for kids. There are possibly some adults that really freak out when husband or wife goes to work or something. I don't know, they have to stay home alone. I suppose it happens to adults, but basically it's a childhood disorder. As is generally selective mutism. But these are just for you to get a picture of all the disorders in the DSM that come under the rubric of anxiety. And normally what you'll see with your clients here is generalized anxiety disorder, agoraphobia, panic disorder, and social anxiety. Those are the most common ones that we're likely to come across. And in treating the anxiety disorders, we had a similar slide earlier. all kinds of drugs may be used to reduce anxiety. So you have your hypnotics, your sedatives, the minor tranquilizers. The major ones are the antipsychotics. These are the minor tranquilizer, and even the antidepressants, very commonly prescribed for anxiety, very, very commonly. I asked one of my private patient clients who has the most unbelievably anxious anxiety you've ever seen in your life. I had her go to a doctor and get her prescribed onto an antidepressant, and she got Zoloft. Now here are the generally pro rata, meaning as needed, medications for anxiety disorders. I know you've all heard of Valium, Klonopin, Ativan, Xanax. Buspar is very common. The ones with the yellow stars are the benzodiazepines. Neurontin is really for neurological pain, very effective. It's a very good drug that has very little side effect. So that's great for anxiety. And these were the very, very serious sedatives that are almost never prescribed. These are the drugs that when I was growing up in the 60s, people would take not to get high, but to get out of it. And you might remember sodium pentothal is a truth serum. Have you ever heard of truth serum? Like they're torturing somebody and they give them sodium pentothal. You know, it kind of knocks them out, but then you start asking them questions and they start answering the questions. I don't know if they tell the truth, but very strong drugs. We typically don't prescribe them anymore. I'd like you to take a look at this slide another time. It's an advertisement for Valium that was targeted to 35-year-old single and psychoneurotic women. There's an ad in the news, an ad in the magazines. That's what it looked like. I don't have to say too much about it. You can read it. You'll either get very angry about it but that's how they were advertised. Okay, personality disorders, a whole class of mental health illnesses, right? This formatted badly. I'm really sorry, because the formatting should have the clusters at the top, but these are on my slide it looks fine, but on your slide it doesn't. This is the breakdown of the different personality disorders in the DSM. I'm not going to belabor that. I'll talk more about what we prescribe for them. Right? I'm sure you've seen almost all of these personality disorders. Okay. Okay, here's the truth of the matter. Personality disorders do not respond to medication. Okay? You prescribe somebody who's got a personality disorder, narcissism, borderline personality disorder, schizoid personality disorder, obsessive compulsive. None of these drugs fix any of those problems, but they are prescribed for symptoms that are attendant to these disorders. In other words, if you're narcissistic, if you have borderline personality disorder, there's really a good chance you'll also be anxious, depressed, you know, all of these things that you can help mitigate for the client, but it's not addressing their personality disorder at all. That won't happen. The only thing that you can do with them is talk therapy, and that has a very low likelihood of working, right? So you might be lucky working with someone with borderline personality disorder. Maybe after 7 or 8 years, you might make some progress. I'm giving you like a worst case scenario, but they're incredibly difficult to treat. And that's why health insurance companies don't like to reimburse. Like I can't get like reimbursement as a talk therapist if I write down that the person has like personality disorder. The health insurance companies are going to go, well, that can't be fixed, so we're not going to pay for that. So we don't generally write that when we're looking for benefits. So try the following and good luck means basically every drug that we have talked about can be thrown at a personality disorder if there are symptoms that warrant those medications.
Hey, Bill, Laura just asked, what about DBT?
DBT is the preferred talk therapy for borderline personality disorder, and it does have a track record of being very useful. CBT a little bit less so, but dialectical behavioral therapy was developed by Marsha Linehan, who was borderline herself and cured herself. I mean, there are extraordinary people in the world. And she figured out how to do it. She probably had help of a therapist. She put together this treatment called dialectical behavioral therapy. And it does work, but I will caution you that we are talking almost always about minimally several years. I mean, no one gets better on DBT in a year or two, and if they do, they didn't have a personality disorder. They were misdiagnosed. That's how that would work. Okay. Yes, it is. It is. If you know any, but that's just borderline. That's not going to necessarily. That is not necessarily going to help somebody with obsessive compulsive personality disorder. Definitely not schizoid and schizotypal, avoidant. Not necessarily any of those. It was really strictly developed for borderline personality disorder. Okay, I love this slide. That was me when I was a kid, but I didn't have ADHD. I just was that kid. Okay. Let's see. Got to be careful with ADHD. Often misdiagnosed. They come in three types: the inattentive, the hyperactive, and impulsive. That's what I think we just looked at. And a combined type. We know it's a neurological disorder, right? It's not a mental illness, right? I wouldn't call it a mental illness. Many people who are ADHD are high functioning, and they are commonly prescribed. If they really have ADHD, the way you know that the diagnosis is correct is if you've given them these medications and they end up working. If they don't work, the kid or the adult ADHD person is probably misdiagnosed, more than likely. Adderall is used very commonly with adults. Ritalin and Concerta mostly with more with kids, younger people, right? So if they don't improve, you might start to look for something else, whether it's, hey, maybe they're just boys. You know, sometimes boys have a lot of trouble, girls too, of course. You know, I'm generalizing. A lot of boys do present with features of ADHD, speaking of which, doesn't mean that they actually, you know, fulfill the diagnosis. And you want to be very careful not to medicate kids that really don't have the diagnosis, just you think they have. And obviously, our poorer clients will get misdiagnosed so much more frequently, obviously, than clients of means, families of means. Okay, as I'm zipping through it, we have one more category left. I'm sure you'll be happy to hear that. I would love to have spent a lot more time on each slide, but either you would fall asleep or somebody would come and shoot me. So I'm going to finish up with Oh, these are the I'm sorry, I didn't show you the slide. These are the non-stimulants because almost all of the ADHD medications are versions of amphetamine, right? Methamphetamine or amphetamine. You know, it's like Breaking Bad. That's what they give them. But there are some non-stimulants that, here's our friend imipramine. Okay, last but not least, substance-related and addictive disorders. Please take note of the name of that category, substance-related and addictive disorders. Okay, also the formatting is all messed up, but the different categories of substance use disorder, alcohol, caffeine, cannabis, hallucinogen, inhalants. We don't see too much inhalants, you know, people sniffing paint or glue, but you see it every so often. Opioids, sedatives, hypnotics, anxiolytics, stimulants, meth, or biamphetamine, regular amphetamine, or Adderall, right? Tobacco can be a substance use disorder. And they actually, in the DSM, include gambling, even though it's not a substance, but everything about gambling and the way people behave and the way you might want to treat it is very, very similar to people who have substance use disorders. If you think about them in a similar way, the treatment can be, you know, you can develop the same treatments. Okay, last but not least, this is the last slide, and this is the most commonly prescribed medications for substance-related disorder. Now, I'm going to tell you this. Most of the models that our patients, that our clients go to when they're in a program are relapse prevention models, or they are based on the 12-step, like AA or NA models. We know, I think we know, that only works for about 50%, 46% of people that go to these meetings benefit from it. There's a lot of people that don't benefit from it. What I don't like is that we have programs that we frequently do refer to that don't want to use medications to help people in their substance recovery. I find that to be almost like malpractice. Everybody's different. There are people, and I know some of them personally, who benefited from being on medications to stop, let's say, a heroin disorder, an opiate disorder. If you go to, what is it called? The name of the center on 36, I'll think about it in a second. But I know a program where everybody who comes in with an opiate disorder is given naltrexone, that's Vivitrol, right? That could be depot as either a shot or it could be orally, right? And they get that all the time, and that inhibits the opiate receptor so that if you use heroin or anything else, the receptor won't allow it because the Vivitrol blocks it. But in addition, they will add to the Vivitrol an antidepressant like Remeron so people can get to sleep, because that's often another problem with people who are on opiates. When they're not on it, they can't sleep. So an antidepressant, maybe an anxiolytic like Neurontin, gabapentin. So I'm a fan of making sure that you address every person as an individual. And if it's medications that they need in addition to counseling, well, then that's what they should get, because they can recover that way. Methadone does not help anybody recover. It's simply a maintenance drug they're not going to recover. These other drugs, there's a like Revia or Vivitrol, there's a hope that they will recover with the appropriate counseling and medication prescriptions. So I'm sorry, I felt a little bit like I was trying to zip through this as quickly as I can. I really had a lot more to say probably about any and every one of the slides, but that's not how we do things. It's not really possible. But I did give you the slideshow so that you can go back and check them out. And I have substantial notes on just about every slide that I showed you. So if you have any questions or you want any more information and you're tired of Google, you can certainly give me a call or email me. And I'm really happy to talk about this subject because I just find it really interesting. So I guess that's why they let me do the presentation. So with that, I hope that it was okay for you guys. Fill out your review form. Yeah.
Bill, want to
yes.
answer any questions or ask if there
Yes, I'm happy to stay here till 6 o'clock if people have questions. I got nowhere to go except maybe the next room. So if you want to unmute yourself and ask a question, boy, oh boy, that sounds like I'm teaching class again back at Hunter.
For the social workers who are getting CLE credits, there is an evaluation that's going to be attached to this. Please fill it out.
Oh, and the name of the program that I couldn't remember off the top of my head, I don't know why, it's called the Parallax Center. Parallax, it's on 32nd Street in Manhattan. And when you walk into this facility, you don't feel like you've entered a drug treatment program. It feels like you entered a relatively high-class doctor suite with a beautiful waiting room, and their conceptualization is that they can help your your substance use disorder best through counseling and medication. And they will give you as many medications as you might need, sometimes 2, 3, or 4, right, to get you through this period of getting used to not using substances. Got to be like the worst time in your life. You probably feel better when you're on them. When you're trying to get off them, life can be really, really miserable. Okay, and I'm happy to take any questions.
Hey, Bill.
Yeah, go ahead.
It's Dane. I have a question.
Okay, Dane.
When you were mentioning the atypicals versus the typicals, I don't know if I missed it, but why now are atypicals more prescribed than typicals? Have atypicals been found to be better?
The typicals were the first ones. They were developed in the 50s, and they worked extremely well on the positive symptoms of psychosis. So in other words, when you see somebody being delusional, hallucinating, those drugs work really well. The problem is they had a lot of side effects. Movement disorders, tardive dyskinesia. These are like neurological disorders that can literally be kicked up by these drugs, some of which may be irreversible. So like just stopping the drug may not be, enough to, you may have gone too far already. So they're a little bit dangerous. They're much more dangerous than the atypicals, which came later in the 90s. So that's why we want to err on the side of caution. The atypicals are not as effective, but they are certainly effective enough that it makes sense to use those instead of the typicals. The typicals are still used, like Haldol and Thorazine are still used when the atypicals are not effective.
Understood. All right, great. Thank you.
Okay.
Erica says, so many of our clients have experienced some form of trauma. Can you speak about PTSD?
Well, I mean, I think I know PTSD as almost all of you guys, social workers in particular, know it. It could come from events in childhood. It could come from events last week as an adult. It's a traumatic experience. This does not have to be something necessarily that happened to you. You could simply witness, like a lot of our clients were little kids, they watched violence in the neighborhood. Maybe nothing happened to them directly, or they saw their parents fighting, hurting each other. These are traumatic events. So even if it doesn't happen to them, traumas are everywhere. Traumas can happen very easily, and they can be debilitating, excuse me, throughout your life. I'm thinking, Erica, you're asking more about what the drugs are, or I mean, did you want me to speak more towards, what the disorder actually is? Because I think most of us kind of recognize it pretty well.
Hi. Can you hear me?
Yeah.
Oh, because hold on, let me turn off. Because I have to log on to speak on my phone.
Okay.
Because a lot of our clients, have experienced trauma, right? Some form of trauma or traumas.
Yep.
And it presents in different ways. And I found that some of them have been like misdiagnosed, or mislabeled, where they're told, oh, well, my son is acting out. He's always acted out in school.
Give him drugs.
Been given different type of medication, right? They're given something for ADHD when they really are suffering from PTSD, right?
Right.
And then that carries on into their adulthood. And then it doesn't get really addressed until like when they're way into the, in the criminal justice system, and, they might be behind bars or just, all their life gone through being mislabeled, right? And mistreated, when in fact they have been survivors of trauma. And that's what's really it. So I don't know if you could speak a little bit about that. And is there treatment? Is there not treatment? Because I've been asked sometimes, well, what kind of medication is there for PTSD? And I'm like, well,
Right. Well,
it's not just that simple.
I'll do my best to answer it. And I'll also simultaneously be answering Michael. Was it Michael or Natalie? I'm interested. Both. Michael wrote a similar question about the effects of the psychotropic meds on developing minds, young adolescents or younger. So I'll try to put them all together. It's super difficult for people of means, middle-class people, upper middle-class people, to really get a proper diagnosis, particularly with kids. It could be that the kid has a dietary problem, right? Maybe allergic to lactate intolerance or something like that. And it doesn't really get diagnosed properly. Now, if it's that hard to diagnose people who have means, think of our clients. They just want to get their kids out of their hair. I'm not saying that the parents are bad parents. The schools want to get the kids medicated. I mean, the simplest thing appears to be to just toss medication at these kids, whether it's going to be effective because they have the right diagnosis or not. You know how much time you have to spend with a kid to really get the right diagnosis? Not an hour, not 2 hours, probably more than 5 or 6 hours. Or hang out in their home with a hidden camera and really figure out who this kid is, right? So it could be that trauma is underlying a lot of the ADHD putative diagnoses. That wouldn't surprise me at all. What the effects of these heavy-duty drugs have on kids' minds, nobody knows. I can't imagine that it's good, with the exception of grade school kids that maybe are doing better because of Ritalin. Maybe you can I think you can make an argument. A lot of parents will say, my kid couldn't go to school until he was on Ritalin, and that really worked. So that's how you really know the kid had ADHD. But for PTSD, it really kind of depends on what this particular person's symptoms are. Are they more anxious? Are they more depressed? Are they behaving? Okay, I want to say this in a delicate way. Are they behaving sort of psychotically? Now, there was an argument that used to be made, maybe still is, that there's no such thing as borderline personality disorder. There's only PTSD. And what you'll find is if you have someone that appears to you to be a borderline personality disorder, they nearly always, not always, but very often, have trauma histories, and they end up as borderline personality disorder. So there are some people that didn't have the traumatic history that are borderline, but if you think of them, if you think of the PTSD person who also has borderline personality disorder, well, what are you going to treat them with? You have dialectical behavioral therapy, but in the meantime, they might be very depressed, so you give them an antidepressant. They might be anxious, so you might give them an anxiolytic. And why I said psychotic is because people with borderline personality disorder frequently present almost like they're psychotic. That's why you got the name borderline, because these people operate on the border between psychosis and what we call like normal neurotics, right? We're all normal neurotics. We have our problems. And
Unknown participant is now exiting.
So the borderline is when sometimes people appear like they might be psychotic, but we know they're not. So you might want to give them a very low dose of an antipsychotic drug to help them with the PTSD and with the borderline. So I think what the short answer to your question is, depending on what that PTSD is and what the main features are, in other words, the main symptoms, you want to address the main, you want to provide symptom relief. That's what you're trying to do. And hopefully if you can give symptom relief to any disorder, then the talk therapy, has a much better potential of working. I don't know if that answered the question. Well, if there are any, I'm here if there are any other questions.
Emily Daughtery, she just said something about medication for PTSD.
I think that's what we were just talking about.
Oh, yeah, sorry, yeah.
Yeah, Zoloft is I see she wrote Zoloft. Yeah, sure, because people are depressed when they have PTSD. Could you use I think you could use any, I think you can use any antidepressant on PTSD because everybody tolerates all of them differently. I see, Emily, you also wrote mood stabilizers. That's really interesting, right? Because, we said before that many of the personality disorders are now, this is relatively new, being prescribed every kind of drug you can think of, including mood stabilizers, which are predominantly for bipolar disorder, to prevent you from doing the manic depressive thing, right? So, like I said earlier, all of these drugs are prescribed off-label for something that they weren't really intended for. But who cares? As long as they work, right? It doesn't matter what you intended them as a scientist to work for. If they help somebody, they should have access to it.
Great. If there are no other questions, we'll be uploading the PowerPoint presentation now. And I think an attachment that you wanted to give out, Bill.
Yeah.
I have the attachment, but I don't have the, and Brenda says a reminder about signing in and completing the survey or else you will not get your credits. Lots of thanks to Bill. This was great. Do you have the PowerPoint file? Would you be able to upload that, Bill?
Okay, I think I just added it to...
With the paperclip, as Laura said.
Paperclip.
Mm-hmm.
Replays, okay. And I have to enter. And then I have one other sheet that I promised everybody, which is the medication cheat sheet that I think is really good. And let me upload that one for you all.
Oh, I think I just sent the cheat sheet.
Oh, you did?
Yeah, but not the PowerPoint.
Oh, okay, I did that. I don't see the,
It's sending.
oh, it's sending. Okay, cool. Where is it? See if
And
it came up.
it should be shared now. Yes.
It's there. I see it.
Say it now? Oh, the quick reference. Yes, great. Okay, so everybody, if anyone is still there, this quick reference is a really great resource to hang by your desk or wherever, or when your cousin or best friends call and ask you what medication you think they should be on. You have your little sheet here, and I color highlighted it. I think the one that's uploaded there is probably reverse page 2 is before page 1, but it really doesn't matter because they just flip over. I highlighted it with markers to make it a little bit easier to see the differences between some of the within some of the categories. So yeah, that quick reference is, I think it's really useful. Thank you for doing that, Rita.
Of course.
Appreciate
I
it.
don't see
And
the PowerPoint. Was that able to be uploaded?
The what?
The PowerPoint?
It didn't come? It looks here like it went up.
Did you enter for type a new message, press enter?
I think I did. I tried to. Oh, there you go. Wait. Yeah. I thought I actually sent it.
It might take a minute to come through.
Okay. Okay. Just let me know if it does. And like I said, anybody who wants, you know, this slideshow, I can email it if you didn't get it. You can tell your buddies or anybody that might be interested in it. And also, just everybody, I really want to thank Rita for helping me helping me with the tech work. Laura Vest also helped me with it. That was much appreciated. I want to thank Gitla and Alicia for encouraging me to make these presentations. You know, I really like doing it. You know how narcissists are. We like, I really like to do these presentations, so they're fun. A lot of work though. Sometimes I wonder why I get into it, but I really, at the end of the day, really enjoy it. And I wish we had more time for Q&A. But like I said, give me a call, email me. I'll spend time on the phone with you.
Thank you so much, Bill. This is great.
Thank you for coming, everybody. I appreciate you taking time out of your day. And I got you out before 5 o'clock.
Bill, thank you so much. This was really informative. I really appreciate it.
Thank you, Bill.
Thank you, everybody.
Unknown participant is now exiting.
Thanks, Bill. I will never look at
welcome.
pandas the same way.
You'll never look at what?
Pandas.
Panda bears. Well, they got the black and the white, you know.
Unknown participant is now exiting.
Oh, everybody's thanking me. Beautiful. Thank you, everybody. It was fun. I just wish I had a lot more time. Then you kill me. Yeah.
Bill, it's Sasha. Quick question. First of all, that was awesome. Did you send the PowerPoint in the chat thingy?
Yeah, it came out on this. If you look at where it says meeting chat.
Yeah.
It got posted. It didn't go?
I don't see it. I doesn't seem like most people see it.
All right, let me just do it one more time, okay?
Okay.
Not sure why it wouldn't have done it, but let's see.
Otherwise, maybe it could be emailed to everybody.
Well, that's for sure. If you email me that you need it, that's not a problem. But I'm going to try it one more time. I thought I tried it twice. Upload from my computer. And Rita says it might take about a minute.
Catherine, I see that you're using screenshots. I'm using that a lot in trying to talk people through Teams.
I love them. Bill and Rita, hi, it's Getzel. I just wanted to say thank you so much. While I had to leave a little bit in the middle, I kept it on because I was coming in and out and I was watching and listening. Excellent. I really, really appreciate it. And you guys make a really good team. Thank you, thank you, thank you. And I want to wish everyone a good night. Now I'm officially hanging up, but great work. Thank you so much. Bye.
Thank you.
Thank you. Rita, you know what? I don't see it coming up, the PowerPoint. I put it in the type new message with the paperclip. I sent it. I hit the arrow. I did all that stuff. But when I click right now on upload from my computer, it doesn't do anything. It doesn't go.
Do you want to email it to me?
Here we go. Here we go. Here we go. Upload from my computer. Here we go. Desktop. Okay, hopefully this is going to work now.
It's probably taking a second to upload, but if you want to email it to me too, I can then put it into the chat.
Okay, I'll do that. Okay, so I'll email it to you, Rita, and I think everybody heard that if they need it from me, they know they can also get it through email, but I did put it on now twice. I don't see that it uploaded, but I put it in there. I clicked on the arrow or the airplane. Catherine Gonzalez reminded me, thank you. But I'm not seeing it, so I don't know what to tell you. I'll email it to you now. New message. I'm getting the little wheelie is all I'm getting here. I guess my computer has too many windows. Here we go. How do you want to share these files? Attaches a copy. There you go. So I sent you the PowerPoint and I sent you the PDF both.
Cool. I'm waiting on my email to come through.
Sasha, you still there?
Yes.
Hi, Sasha. I
Hi,
like when you
Bill.
said, you go, hi, you go, this is Sasha. I'm like, you didn't even have to say that. As soon as you said hi, I knew who you were.
Oh boy. Just trying to figure out where this magical PowerPoint is. It really was super useful.
What's that?
No, it was a really useful presentation.
Oh, good, thanks. You know, you try. Look, Rita and I both tried to add it into this chat thing. I tried twice. It looked like it was going to do it, but don't ask me. I really don't know. But if you don't get it, you know how to get me.
Yeah.
Yeah, I don't know. It's acting really funky. I don't know. When it goes to upload from my computer, it's doing weird things. Oh, well.
I mean, it's the end of the day. The internet's probably given up at this point. I can absolutely email it out to all staff if Gittle says that's all right, or upload it into this chat at a later time.
Yeah, just put it in the chat because, you know, all staff, not everybody was going to really want it. And I think, but, and everybody knows how to reach me, you know, whoever wants it, anyone who wants it will go out of their way to get it, I think.
Okay, great.
And everybody else, I still see a few of you are here. Brenda, hi. Catherine, hi. Elizabeth, Jenny, hi, Jenny. Katrina, Joan, hello, everyone. Nicole, Pierre.
All right, then if we're gonna email out later, then I'll see you guys later. I'm gonna head out.
All right, well, thanks
All
for
right.
coming.
Again.
So,
I'll
bye,
shoot you.
guys.
Bye.
Bye. Bye, Bill. Thank you.
You're welcome. Thanks for coming. All right, Rita, I think we should take off.
Great. I'm gonna end or exit out, and then this will be recorded, and then I'll send that out into the chat too.
You're the best. Thank you so much for spending your day with me here.
Of course. I really enjoyed this.
Oh, great. Okay.
Have a good night.
You too. See you, Jenny.